Hello, this is Dr. Scott Worden, the TOS guy, live streaming from beautiful downtown Sunnyvale, California. We're heading back into a second summer here. It's getting hot. Today, we have a really hot group of speakers. We are so lucky. We have two excellent young progressive TOS specialists from Emory University. And I'm going to try to cover their introductions briefly, but I'll probably leave out a lot because they both have a distinguished early career. We have Dr. Eric Wagner, who's an associate professor of orthopedic surgery and hand surgery. He did a residency at Mayo Clinic, the famous Mayo Clinic. He did a fellowship in hand and microvascular surgery, also at the Mayo Clinic. And then he was invited to a very specialized and elite international shoulder and elbow fellowship in Massachusetts General and Brigham and Women's Hospitals in Boston. We also have Robbie Bowers, who is a team physician for the Atlanta Braves, among other teams. He's an assistant professor of orthopedic sports medicine and sports medicine. He did a residency in physiatry, I believe, and a fellowship in sports medicine. Gentlemen, did I get any of that right? I hope I did.
Yeah.
Yep.
All right. Now, these two gentlemen work together at Emory, and they have worked up a really beautiful protocol and paradigm for addressing TOS patients, as well as the multiple other shoulder maladies that may be confused or contribute to TOS. So, first of all, I'm going to send the first question to you, Eric. How did you guys start working together, and about how long ago was that?
Yeah, so we've been working together basically since we both kind of started very similar times at Emory, and then sort of realized we had sort of mutual interest in a variety of things, not just TOS, but a variety of kind of the more complex upper extremity pathologies that deal with like regular people as well as some of the overhead throwing athletes and sort of then sort of realize, Bowers really pushes the envelope with regards to ultrasound and some of the really innovative aspects in that area. And so I from a surgical standpoint, like to do a lot of the kind of the innovative arthroscopic stuff. And so it felt like we had a very complementary sort of interest in doing things and seeing some of the more challenging and more difficult stuff. And then it kind of evolved into TOS being one area that we both recognized was a very sort of maybe evolving field with a lot of room to improve, but also a lot of room to kind of better understand and innovate. And so,
And Robbie, how about you from your point of view? How did you get started with TOS?
Yeah. So, like Eric said, we started at Emory right around the same time, and I think just naturally, through our interests, is kind of linked up. And I think the good thing about both of us is what we do is complementary. So him on the surgical side and myself on the non-surgical side. So it works really well together because we can both, kind of be experts in our particular aspect of thoracic outlet syndrome and how we work it up and treat it. And so it works very well and complement with each other. As far as me in particular, I mean, part of it was, the people that Eric trained with that, I think he already had an interest in it, and in me having a specialized interest in overhead throwing athletes and baseball players, which have about a 3 times more likely chance of getting thoracic outlet syndrome because of the repetitive overhead activity. It was a natural, just kind of a natural progression. And then I think just with my relationship with Eric and taking care of baseball players, it just, created itself. And some, it's one of these, a niche that you don't necessarily expect to get into, but when you do, I just find it, it's really fascinating, and we're just scratching the surface as far as understanding things, and I think we have the ability to really make a difference for these patients, and then also our understanding and how we work up and treat this condition.
That is great to hear. I second all of those thoughts. We're scratching the surface. We have an opportunity to make a really big difference. So are you seeing, would you say since you started, are you seeing more patients now with TOS than you did a few years ago?
Yes.
Is it because
100%.
they're coming to you? Is it because they're being diagnosed more readily? Is it because the disease is increasing in prevalence?
So
I would say, I'll let Eric go. Okay.
Go.
So my 2 thoughts on that are very brief, in that I think we are better at diagnosing it and recognizing it, number one. because I have patients that come to me all the time that are referrals for ultrasound from other docs for other upper extremity peripheral nerve conditions that I just, in talking with them, you're like, wait a second. And then you go down the thoracic outlet path there. So I think we're just better at recognizing it. And then also, as you treat these patients and their outcomes are successful, word of mouth spreads. And so I think we're seeing more people for it too, and starting to see more people come in from out of town. So those are the two reasons why I would say that we're definitely seeing more now than we used to.
Yeah, I mean, totally agree. It's been like exponentially more. Like when we started and we're sort of like seeing people, it was, every once in a while sort of referrals or certain athletes that we were kind of locally taking care of. But I think with some of the success with the kind of as our algorithmic approach has sort of evolved, I think between word of mouth, between our colleagues better understanding it, I think between even the community, we've had a lot of around Atlanta and around Georgia, there's been a lot of we've had a lot of presentation discussions with various people that I think now recognize it more. And so honestly, I think that hopefully people are finding a home faster than they used to. And yeah, I mean, it's truly gone from maybe, seeing a TOS once a month, like, 4 or 5 years ago, to generally every clinic that I have, I probably have a new TOS referral, and I think Bowers does too. Often we have them kind of combined it where people come in and we'll sort of do joint visits. I literally had 2 people today that I set up for joint visits with Bowers and I from email. So like we are getting these now constantly. Some is real thoracic outlet, some is other pathologies that are being mistaken as thoracic outlet. But I do think that there's a lot of people out there that are being pushed around or not exactly given, not better understood. And I think, it's been a really cool area of our practice that's grown a lot.
I want to introduce this at this point that Dr. Wagner has done a great talk on YouTube. You can find, just search for Rethinking Thoracic Outlet Syndrome. And it really starts out with a great discussion of all the shoulder pathology that might be confused, and then branches into TOS and starts discussing the mechanisms, which I believe are not fully understood at this point. I'll diverge to my little soapbox that when Pete in 1952 said, let's just call all of these various syndromes TOS, I think he did a disservice because there's so much underlying anatomic change. We have the superimposed dynamic changes that we're starting to understand, I believe, through imaging and other methods. And I think it's still a bunch of related but different syndromes. What do you feel about that?
Could not agree more. I mean, so TOS is like this broad, I think it's forever been this broad term that's all encompassing, looking at like vascular, so venous or arterial congestion, looking at different forms of neurogenic compression and sometimes it's like a static thing, extra rib. Sometimes it's a and then other circumstances, it's maybe more of a dynamic, dynamic with bones involved. Maybe it's more dynamic with more of the soft tissue. I mean, I think the dynamic aspect of quote unquote TOS is something I think we are really learning more and more about. And I think that's something that imaging and like diagnostic injections, these things are helping us to better understand some of these aspects of this dynamic process. Because very rarely is it something that's like an obvious static, hey, this is your problem. You have a cervical rib, you have a something that like clearly is causing a vascular component that's creating your symptoms. Often it's a dynamic process, so it's super hard to pinpoint. And I think that's where a lot of the confusion comes in. I also agree with you. I think that we're starting to understand all the different subvariations. I think, I think blaming everything on the first rib is probably not the most appropriate way of going for everything. I think we're still understanding the interplay between scalenes and the first rib and the pec minor and the subclavius and the suprachiasmatic nerve and the shoulder girdle itself and how the arm moves. And there's so much to this that, at least from my perspective, it's starting to, we're just starting to touch the surface of really understanding all the different subvariations of what quote unquote thoracic outlet means.
Robbie, do you want to add to that?
Yeah, so I'll just piggyback on it a little bit and say it is to say at this point in time that thoracic outlet syndrome is just, a clinical diagnosis you make in the office based on a couple physical examination tests that we know for a fact aren't very good, and you send someone to physical therapy and they fail that after a couple months, and then you just take out the rib like that. That's a very rudimentary approach to this, yet it still is something that new papers come out on thoracic outlet, and that's where it begins and that's where it ends. And there's not very much discussion at all about the dynamic component of this and the varying areas of compression, and where one can be more predominant than the other. And based on that area of compression and what nerves are involved can significantly alter the treatment. And it's not just you do physical therapy or you have a rib resected. I think that shotgun approach that is still very prevalent out there is very ill advised.
And I would add, I'm not trying to take this personally, but there are a lot of places that very famous institutions with great people who talk like that and model it like that and don't do imaging. And for me, that's it's a little hard to accept. We have all this data we can get imaging. Geez, I'm just so overwhelmed by the amazing imaging that people have developed. We can see these things when we apply these tools, and not to use it and to leave it as a big lump of diseases that you approach in the same way all the time troubles me. If it were my family member getting this surgery, I would not be happy with that, knowing what I know now. So now, forgetting the imaging for a second, Robbie, you do some really specialized injections, and those are built on logic. And maybe you could explain a little bit about how you dress the scalene or the pec minor and what you do with these
Right.
injections.
Yeah, right. So I just gave, Eric thankfully invited me to give a talk on this specific topic, the utilization of ultrasound and ultrasound guided injections and the diagnosis and treatment of thoracic outlet syndrome, just at the Hand Society meeting last week or 2 weeks ago. And we can do great things with ultrasound now as far as identifying structures. I tell people a lot, I mean, unless there is a mass or a cyst or something, we're probably not going to necessarily diagnose based on the ultrasound. But you can do dynamic maneuvers with the ultrasound. So you can put it on the pec minor and you can bring their arm up overhead, and you can look to see if those neurovascular structures under the pec minor compress and create some bowing of the muscle, which is in a normal person without TOS. The theory is that you won't see bowing up of the muscle. You'll just see the muscle kind of drape across. But with thoracic outlet and a kind of chronically adaptively shortened pectoralis minor, it's so short when you bring the arm overhead, everything pushes up underneath it and the pec minor bows. So that can be a diagnostic tool and we can use that, but it's definitely not the end all be all. It can just help in the diagnosis. The way that I strongly feel and the way that I get the most information is to do the diagnostic injections. And we typically will, we can get with our high resolution ultrasounds now, we can get really beautiful pictures of the pec minor and the underlying brachial plexus and the neurovascular structures, as well as C5, C6, C7, C8 roots coming between the scalenes at the neck. We can get really good pictures of that. And the ultrasound allows us to be very precise in our injections. And what I mention all the time is that it's not just a muscle problem. It's just that the muscles are shortened. It's also the nerves are irritated. So it's a muscle problem and a nerve problem. And you can't just go, especially with the blind injection, but even with ultrasound, you can't just inject a little bit into the muscle. You have to include the nerve structures in order to get all the structure to get the most information. That is my feeling on this. And I think that part is very important. And ultrasound and high resolution ultrasound allows us to do that. So beyond the two main areas of the scalene and the pec minor, and we can inject the subclavius as well, are also the secondary nerves that we think may be involved, whether that's the dorsal scapular nerve or the suprascapular nerve, or whether they have quadrilateral space syndrome that's occurring at the same time, and we can inject there as well. So there are a number of nerve structures that we can inject with ultrasound guidance to pinpoint and piece together all the different nerves that are involved, not just the main kind of areas where you think about thoracic outlet compression.
Now, you mentioned these as diagnostic, meaning you're using a short-acting anesthetic like lidocaine, right?
Right, short acting and longer acting. So lidocaine and ropivacaine,
Okay.
and
So if
that
you
is
get a
more.
positive response, let's say you go and you do a pec minor injection and a
Yeah,
suprascapular notch slash nerve
yeah,
injection because you suspect that, and you get
hmm
a positive response, you've now narrowed it down to a couple of
right.
pain generators.
And I think it's important to note that the injections are staged. So you're not going to do these injections at
Mhm.
the same time. You're going to
Yeah.
do one, you're going to give it some time, you're going to give it a week or at least a few days to wash out and then do the next injection. To go in there and shotgun inject the pec minor and the scalenes. And some people might say, oh, the lidocaine kicks in quickly. You'll know you can do one and then do the other. In my clinical experience, I don't find it to work that quickly. I think if we have to give it some time for everything to set in. And so I typically won't get responses from patients until much later in the day as far as, okay, I feel I've been able to go
Right.
home. I've been able to move around and do these specific things that make my symptoms worse. So if it's a baseball player, I'll do the diagnostic injection and they go throw a baseball to see how their symptoms respond. So you have to give it that time and stage the injections. And then, that's part of our tool, that we also have to use our physical examination skills and understanding the anatomy to know which other nerves that we think may be involved, so that we have a plan as far as what staged
Mhm.
injections we want to do.
So for our listeners, some of whom have had an injection of their anterior scalene, their middle scalene, their pec minor, and their subclavius at the same time, when they get a positive result, what do you
You're
do
getting
with
you're
that?
getting your rib taken out.
Well,
That's
yeah,
that's what
and maybe that's the
that's what
purpose of
happens.
doing it. Yeah.
Yeah,
Yeah,
yeah. So
so the
you have
original
to.
the original literature from LA in the 1970s on doing not even an ultrasound guided block of the anterior scalene and that leading to surgery. I have a lot of trouble if you've read any of that. They had no controls and it just seemed like an excuse to go to surgery. Any thoughts on that if you know that literature?
Yeah, I mean, here's my 2 cents is to piggyback on what Bauer was saying. I mean, it's you get a positive response to get a diagnosis, not to get necessarily a treatment plan. So we get a positive response, but this is, I mean, most of the time we're seeing these patients early on. They maybe have had some therapy, but like, maybe not necessarily our protocol, or not necessarily a protocol. I think that fights against some of the deforming forces, like Bowers was mentioning, the scapular protraction and the shortening of the front part of your shoulder, fighting against that with a figure of 8 brace, fighting against that with a scapular directed therapy protocol, opening up your
Mhm.
chest, stuff like that. So you make a diagnosis, meaning, hey, this is maybe neurogenic TOS driven by the pec minor, neurogenic TOS driven by the skins. Maybe this is, something else, quadrilateral space, but you come up with a diagnosis based off of imaging. So the imaging that we get based off of these injections, and series of injections. And then you can start treatment. And honestly, Bowers can talk about this more, but we've had some very great success stories, or Bowers in particular has some really great success stories doing Botox as a
Mhm.
secondary follow-up and getting some really nice responses to that. And not that Botox is permanent, it's not permanent, but what it does is it gives you maybe that jump start to therapy
Right.
to correct what was already like happening. If this is a dynamic process, theoretically, you can dynamically like correct your and retrain your body to not do what it's been doing that causes that problem. Honestly, surgery from my perspective as a surgeon, what I'm doing with surgery is I'm just doing a little bit more permanent version of that, where I'm correcting something that was off. Maybe it's the scalenes, maybe it's the pec minor, but you're correcting something that was off and that's driving this process. But the patients still have to actually go through the therapy protocol, still have to actually correct it themselves. And but if you can avoid surgery and just do Botox, I mean, that's a great way of doing it too. So it's interesting because like a lot of the old papers use these as surgical indicators, and I think from our perspective, that we both have kind of evolved into, we sort of play it by patient, circumstance for circumstance, how long they've been dealing with it. But there's definitely, somebody comes to us right out of the blue, there's no way they're getting surgery. Even if they get a good response to the injection, they're going to start with a whole protocol that potentially we can treat without surgery. And we've done this over and over again. As many surgery, so we have a couple of papers coming out. We've had one paper coming out on the surgical response. We've had many papers coming out, or that have already come out on our algorithmic approach. But we have another really large surgical paper coming out on the sort of arthroscopic approach to this, based off of the response to various Bowers injections. We have to realize the number of patients in that paper, there's 3 to 4 times that we didn't do surgery on that got responses from injections and therapy and et cetera. So, I mean, it's
Wonderful.
not, it's full, in my opinion, like this is way too aggressive approach traditionally. So
Can't wait to read those. When I see surgical outcome papers, they often start with, we have X number of patients who were clinically diagnosed with neurogenic thoracic outlet syndrome. Here's our results. And for whatever reason, I just automatically put on my cynical hat.
yeah,
How did you diagnose them?
yeah,
Because the results we get have been the same for decades now. And
yeah,
that's, at least
Right.
from what I've read, 85% of patients are good to a lot better. And then over 2 years, it's dropped down to about 70%.
yeah,
Yeah. And I don't, one thing I'll add is I don't want to sit here and act like I'm villainizing first rib resection. There are a number of patients where first rib resection is the appropriate surgery to have.
Mhm.
It's just, it can't be a shotgun approach. So when we do the stage diagnostic injections, if they have a slam dunk response to the diagnostic scaling injection, they don't get much at all from the pec or from anywhere else, and we think that it's just supraclavicular origin of their symptoms, then that indicates to us, that maybe first rib resection is the most appropriate treatment if we get to the surgical approach. And I've had a number of patients that have had, the vascular surgeon that we work with that's great, that does the, at Emory, that does the first rib resections, that has done that surgery, and it's been life-changing for people as far as faces their symptoms. So I don't want to sit here and act like we're saying that is not indicated in certain situations, but I think that's what's so key and great about our algorithm is through the staged approach, we can pinpoint the places where the compression is happening, and that can drastically change which surgery is most appropriate, from very minimally invasive to more invasive, like a first rib resection.
Right.
And if you're most appropriate for first rib resection, then we'll tell you that, and that's the most appropriate route. But there are other ways to go about things. And like Eric said, I just pulled all of my TOS Botox patients, and I'm going to go through and just follow up with them and see, how many of these patients are we treating with Botox that do get a definitive response, because it does happen. But now I just want to get those numbers and say, of the ones I've treated with Botox, what percentage of them are getting better permanently or at least for a longer period of time. Because what we see in the literature, like you said, it's really hasn't shown anything that Botox is an appropriate definitive treatment. It's more that it portends a positive surgical outcome in most cases. But in my clinical experience, it can certainly be definitive when you relax the muscle. This isn't aesthetic Botox, like Eric said. We're not doing it every 3 months. It's active for 3 months. We try to give the muscle a jump start to relax, and then let the therapy do its job so that the muscle doesn't reflexively
Great way to put
contract
it.
back after the therapy. And so I just wanted to kind of touch on that, given that Eric had said, can be definitive, and we have had success with Botox and therapy alone.
Yeah. I'm going to see if we can put up your protocol that you sent us. Herb, do we have access to that? Do you want to point out anything or walk people through this?
Yeah, I mean, this is the sort of thing, and this has been a sort of trial and error. Like I said, we have a certain protocol with regards to both imaging, with regards to trying to diagnose neurogenic, trying to diagnose like sort of vascular signs of compression, trying to diagnose other potential etiologies that might be causing this. That's the first part, and then the injection part is sort of our way of helping to this is one we have a kind of other modifications of this. Sometimes suprachiasmatic nerves included, sometimes it's not. Pec minor and scalings are probably the two main ones that almost everybody gets, and then we'll kind of decide on suprachiasmatic nerve, maybe on quadrant space, depending on where the patient's symptoms are and where they're kind of localizing things. And then we sort of like, it's case by case sort of situation, I think. Everybody who sees us starts out with the lidocaine. I mean, as soon as I get an email about a TOS patient, I immediately set them up to see Bowers and myself, as well as starting this algorithmic approach with regards to some of the imaging. And so they come in, and if they're not from Atlanta, they'll get all this or within a day, maybe 2 days, depending on their schedule. And then and then we sort of like, depending on the next steps, kind of coordinate everything from there. I don't know, Bowers, you want to expand on that?
Yeah, we put, not that this is like an end all be all, but it's a simple way to visualize our algorithm. And like Eric said, not every single person gets a suprascapular nerve block, not every person gets a quadrilateral space injection, but we do, the way this has evolved over time, and we had, at certain points, I think most of our TOS patients now, I will do a PEC and a scalene on them, just because, I feel like that gives us the most information, where previously in years past, maybe we just stopped at a PEC if they got really good relief. But I think it's still helpful to know, is there, are there multiple sites of compression here? And so that we can decide, okay, that they got 80% of their symptoms relieved with a PEC minor injection, but they still got some relief, 15-20% with scalene. So maybe the most appropriate treatment, if they aren't successful with therapy, is Eric does an arthroscopic PEC minor release, and then we Botox their scalene so that we're able to treat both places. And so I think doing both injections is important at this point. And so for almost all of these patients, unless you tell me we do a PEC minor and 100% of your symptoms get better and that was it, I can be convinced not to do a scalene. But in most cases now we're doing both of those. And then, a lot of cases we are doing suprascapular nerve blocks because they're simple, they're easy to do. It's good for us to know if that's a component of the symptoms too, with that chronic scapular protraction puts traction on the suprascapular nerve, and that's the reasoning that we're thinking why that is there, and Eric can expand on that as well. So that's just my 2 cents. I mean, I think this is an easy way to visualize it. There's certainly nuance to it, and it can go a little off track from this algorithm, but this is fairly, consistent with what we stick to.
Thank you for both of you. That's great explanations. Do you follow this? Is it almost always PEC minor before anterior scaling?
I generally start there for no other reason than they are going to get a block when we do the scalene injection. And a lot of people will argue with it. They say, well, isn't their pain going to get better? I've done enough of these, hundreds of them now, to where if that is not the site of compression, their pain, even if their arm is heavy, they don't get pain relief. And so I've seen it time and time again. And
sorry, could you repeat that? I missed a little bit of that.
Yeah. So when they're essentially getting an interscalene block when we do that injection, and their arm will get very heavy. They can still move it, but they have some proprioceptive problems and difficulty with their arm in space for a few hours afterwards. But if that is not the source of their pain, that will not improve their symptoms regardless of how heavy their arm gets. But the reason I mention that is that a lot of patients that do show up to see me and they're by themselves, I won't start with that injection, mainly just because they don't feel comfortable driving with their arm afterwards. So that's the main reason why with the PEC block, they don't have that heaviness in their arm that they have after the scalene block. And so that is generally why we start with the PEC in most cases. But if patients come in and their symptoms are very isolated supraclavicular and I talk them through it, then we'll start with scalenes in certain situations too.
Got it. Thank you. Now, Eric, you had in that talk I referenced, Rethinking Thoracic Outlet Syndrome. You talked about STAM first, about the scapulo-thoracic abnormal movement. Yeah. And the reason I asked Robbie this question about doing PEC minor first is because I'm a little bit cynical about the PEC minor syndrome as I see published many places. I don't think it's always or even often causing compression of the neurovascular bundle. I suspect it's contributing to something which you described as STAM. Do you have any thoughts on that?
Yeah, here's my 2 cents on the whole PEC minor. So I think there's a series of issues that can be associated with the PEC minor. It's the STAM, scapulothoracic abnormal motion. So that's a function. There are many different types of STAM. Some are from paralysis. So basically, it's like a better version of saying scapular dyskinesia. And it's basically can be driven by a paralyzed muscle like the rhomboids, like the trapezius, like the serratus, or it can be an overactive muscle. And the two most common overactive muscles are the PEC minor and the rhomboids. Rhomboids usually that's something that's a kind of a neurogenic or neuromuscular phenomenon that that usually will respond to Botox. The pec minor is something that can create a very functional abnormality. So you can have people with very, very limited actual motion because their shoulder blade's not moving really well, and it's because their pec minor is so contracted down. Alternatively, it can be something that's more of a pain-driven etiology, and that's where you have something that's where by the pec minor contracting down, it brings the scapula forward. So then when you try to move the arm back, up, overhead in any direction, what you're doing is you're stretching your all your other muscles are overpowering the pec minor, bringing it back, but it's compressing, or it's irritating the nerves below it. It's also like messing with that whole kind of infraclavicular thoracic outlet or infraclavicular girdle, where you're tightening up right below the pec minor, you're tightening up right below the subclavius, you're tightening up that whole area with the plexus, with the branches of some of the first branches of the plexus coming off. So sometimes these patients, instead of having a functional abnormality because all their other muscles have kind of overcome it, what it's driving is more of a pain problem. And the pain problem often is you'll see radiating pain either down the back of the shoulder, in the scapula, maybe it's radiating in the more around the shoulder, down the arm. And that's something that like the overhead throwers that we see, that's often what you see is you see the pec minor index, which is, a shortened version of the pec minor on this side compared to this side. You can see the trapezius is more prominent because they're protracted forward. And then you can see when they correct that, and they bring their arm back in extension or overhead, that's when they have the kind of radiating pain. You can, they're pretty tender usually here, tapping here usually sends it to shooting down their arm. It's something that, like, I walk into a room and I can immediately see if somebody has it, just because I can see their shoulder blade, their trapezius being more prominent, their shoulder up like this. And it's funny, since I learned about this, I've been to France. I go to France frequently for conferences and for teaching at conferences. And since I've been there, I've been to the Rodin Museum a couple of times. And if you actually look at the Rodin sculptures, there's multiple people that look like when he was painting it or when he was doing them that probably had this in some form. So it's clearly been around for a while. I just don't know if we've always recognized it. So to answer your question, is the pec minor the only culprit? No, but I do think it creates a scapular girdle problem that then predisposes to things like the TOS. And then I think the scaling can start playing a role. In my mind, there's always like some driving factor. Is that driving factor from like the scalenes bringing the first rib up to the clavicle, or is that driving factor from the pectoralis minor causing the scapular girdle to be out of sort of whack? And that's kind of what our algorithmic approach is trying to figure out, if we think it's neurogenic thoracic outlet. Vascular thoracic outlet is different. There's other compressive neuropathies that are different, but we think it's neurogenic thoracic outlet. We're trying to decide or trying to figure out where's the driving force. What's the main initial problem that's led to all the other problems down the road. So,
excellent explanation. I love that. Robbie, anything to piggyback on that?
Not necessarily. What I will say, Eric's mentioned overhead athletes that, we have found and will publish. We ran our diagnostic block data last year, and we've also done it. So that was October 2022 to October 2023. And now we're doing October 23 to October 24 to add it all together. But in our, as we've run the block data, we do see a majority of people, and I won't, plenty of people have a more primary response to scaling injection. But I think what our block data shows us that is not indicated in the literature at all, and that some TOS papers, a lot of them in the literature, don't mention the pec minor at all. But if you take our staged block data where we've done scalenes and pec minor, there's a majority of people that do better with the pec minor block than the scalene block. And then if you extract or condense that down and just take overhead athletes, it becomes profoundly more positive with overhead athletes. So overhead athletes are much more likely to have pectoralis minor driven neurogenic thoracic outlet syndrome symptoms with STAM involved, just given what they do with them throwing and they're powerfully internally rotating their shoulder with the pec minor adaptively and chronically shortening over time, which leads to STAM and pectoralis minor syndrome together. And so I think that, this is not just something that is based on necessarily a hunch at this point. We have objective data to back up our theories of why these things are happening. And so I would just add that our thoughts on this have been driven by what we've seen with our algorithm and diagnostic blocks.
It's awesome. I really love hearing that. So what we're saying is that pectoralis minor syndrome, for whatever the cause, if the pec minor is the driver, it's really an abnormal posture of the shoulder girdle relative to the chest that has all these secondary knock-on effects, including nerve irritation, compression, or tension. Is that a fair?
Yeah. In
Correct.
some respects, yeah.
Yeah, it's fascinating, different model than what we hear from so many other sources. I'd like to see if we could take a couple of questions from viewers. Herb? All right. Wow. Miles Wandering Wolves, dog and pet surface and boarding. Hello, and thank you for doing this live. Thank you for being here. My question is, why suddenly my TOS is flaring, swelling, and not even doing anything? I presume you're not doing anything and you're getting a flare. Thank you. So when you see patients who get a flare of their TOS and they haven't done anything unusual, how would you approach it?
Yeah, I mean, I think once again, this is a sort of TOS is a complicated catchnet of phrases. So I think it's first trying to understand what type of TOS you have, and that better helps to understand the triggers. And I do think there are many problems that are like TOS, but not actually TOS, have very similar symptoms, but not. So I think the first thing would be is actually confirming that this is the right diagnosis. But let's say it is. Vascular TOS can be flared from a variety of different things, not just motion, not just overhead. And that's something that, when you talk about swelling, that's one of the kind of hallmark things you worry about with regards to, especially if you're talking about extremity swelling or hand swelling. And then neurogenic can also have swelling too, because obviously the nerves, irritated nerves can affect this, but it sort of can flare, just like if you know anything about carpal tunnel is way more common. And when you treat somebody with carpal tunnel syndrome, the worst pain is not when they're typing on their computer. The worst symptoms, the worst numbness, tingling, the worst pain they have is at night when they're sleeping. And so just like any other nerve compression syndrome, that can also play true with TOS. Now, once again, depending on what the type of TOS it is, depending on what you're being driven, so really hard to totally say from a generalistic standpoint. But TOS is not always driven just by the baseball pitchers that Robbie's referring to and that we see a lot, or the overhead athletes. It can come in a lot of different forms and for a lot of different people. So,
yeah. So, my thought is, and exactly like you said, you come in and you tell me this story. Number one, we're going to decide if we actually think that it's TOS is the diagnosis, and we can go through our algorithm and figure that out. Or are there any other peripheral nerve compression syndromes that it could be? Are there any other pain syndromes that are involved? And that's why, working at Emory, we have access to, pain management specialists that know the kind of pain syndromes. And so those are all things we're going to think about. But like Eric said, say that neurogenic thoracic outlet is the diagnosis and it's not vascular, and why are your symptoms flaring randomly? And in the general population, we see a lot of this is postural. People that work desk jobs, so their shoulders are hunched forward, they also can get a chronically kind of compressed and narrowed down thoracic outlet. And you can be doing nothing special and you're just working at a desk and your symptoms get significantly worse. You did one little thing that you didn't even notice and it flares your symptoms. And so it's a very, postural condition as well that we find in the general population. And so those are our thoughts of, if someone was to ask me this question, those would be things I would think of.
Thank you. I wanted to add in something. Do you see many patients who you believe have a component of venous congestion that contributes to neuropathy?
Yeah. I mean, so venous congestion is a big issue. I mean, vascular TOS, that's a big problem, especially if you have venous congestion from an actual blockage underneath the first rib. That's a very different problem than some of the neurogenic things we've been referring to earlier. And then obviously when if you're depending on the prior problems, but I mean, people with lymphedema, they often have neuropathies, or people with chronic kidney disease and fistulas on this side often have neuropathies as a result of that. So your vasculitis or vascular problems often will get secondary nerve issues as a result. So yeah, they all
And,
come into play.
and my question was confusing. I didn't mean typical venous TOS with a, an effort thrombosis, the Paget Schroeder. I meant like McCleary syndrome, where people get venous congestion just from arm position and they
Yeah.
get a congestion neuropathy. I don't know if that's something that you dealt with much, but I see a lot on imaging.
Yeah.
I see with their arms up, the patients get compression of the subclavian veins and their cephalic veins are distended more
Yeah.
than in the arm neutral position.
Yeah.
So when I have a
And
patient ask about swelling,
no, I mean, that's the same idea. Yeah. I mean, when that happens and they do that over and over and over again, that's going to have an impact on the nerve problem. And that's once again, like when you try to differentiate between vascular and neurogenic TOS, and then people talk about how you have both. I really think if you have both, it's probably vascular TOS that just has some nerve components as a result of the vascular compression. It's once again, I think there's always a driving factor, and as you kind of mentioned, then if the vein or the artery, but especially the vein, is getting compressed, I mean that can predispose to having the sensations of numbness, tingling, and the kind of compressive neuropathy type of symptoms, even some lower trunk type symptoms down in the hand, and that's probably, although maybe you call it a mixed vascular and neurogenic TOS, the vascular component is probably a large component of that, and probably a large reason why this is happening. And as Bauer said, I mean, without question, that's the type of person that really responds extremely well to a first rib resection if you come to that. But I also think of Botox into the scalenes and then a therapy protocol is a probably better first step if they haven't had that. So
awesome. Excellent. Thank you for the question. I'll also remind people, including our panel, that we don't answer specific medical questions here for a lot of privacy reasons, that they can reach out to our website, tosmri.com. Not only can we do a consult with me, but we can connect you with these docs that you see here who are obviously highly trained, highly intelligent, and very humble specialists. So, Herb, let's have another question. D cells, can you speak to wrist drop, weak shoulder, and how to strengthen the thumb muscle? Should I be using weights with any of this? And do you know of any physical therapists in Tulsa, Oklahoma? Thanks for the question.
Bowers, you want to take it? Do you want me to?
Go for it.
Yeah. All right. So
some of these are more in your wheelhouse.
So, without question. So wrist drop, weak shoulder, and strengthening thumb muscles. So first off, understanding exactly what all this is. Is it from TOS? Is it from something else, some other type of compressive neuropathy, or just generalized neuropathy in general? The thumb muscle, that's carpal tunnel, if that's what you're talking about, your adductor, versus, there's multiple other 4 or 5 other muscles around your thumb that control its motions. And then obviously the shoulders are very different. So from our perspective, if it's a TOS driven phenomenon, we try to focus on the shoulder blades, the scapula, opening up the thoracic outlet. That's probably the first thing we go to. Then specific weaknesses or areas people have for wrist drop, that's something that's, usually caused by a radial lesion. Maybe that's from the posterior cord if it's TOS, but maybe it's from something else more distal. And that's obviously something if you still have function, you can deal with weights. The weak shoulder is very similar, depends on where it is, but we're kind of correcting the scapulohumeral rhythm, bringing the shoulder blades back, and then in a coordinated fashion, strengthening the many different scapula and glenohumeral stabilizers. And then the thumb, there's this thing called certified hand therapists. I would strongly encourage anybody who has hand symptoms to be working with a CHT. They're great. They can help to isolate various muscles that are weak, and depending on the problem, can even sometimes help treat that. So I would sort of, do this piece by piece. But if it is all from TOS, like start with the scapula, start with the shoulder girdle.
First of all, thank you for the question. And secondly, regarding a physical therapist near you, if you reach out to us through tosmri.com, we will connect you with physical therapists we know who may have a colleague in that area. I wanted to bring up something from your algorithm, gentlemen. You mentioned EMG briefly, and we really didn't discuss it. How much does that contribute, if any, to your decision making?
So I'll let Eric touch on this too. I think every once in a while we'll have a patient, like I just talked to our EMG specialist the other day, that had a true, it looked like a TOS where the medial antebrachial cutaneous nerve was slower on the TOS side versus the non-TOS side. So we'll see that from time to time, but most of the time I think EMG is most useful in ruling in or ruling out other peripheral compressive neuropathies that could concomitantly be causing, they have like a double crush syndrome. If they have thoracic outlet symptoms, but they also have ulnar neuropathy down at the elbow, I think that's where I find EMG to be most helpful, because we have that information, and I'll go down the chain and we'll do diagnostic injections around those nerves as well to see how much of the symptoms are coming from those nerves peripherally. So that's where I find EMG to be the most helpful.
Yeah, I would agree. So, EMG is something that's I think in certain respects can be very very helpful, because it can tell you, hey, the numbness that you have in your hand is probably because you have cubital tunnel syndrome, and maybe it's not something that's a little bit more rare like TOS, or maybe you have cervical radiculopathy that's contributing to this. One of the findings we had in our surgical paper was those that had either preceding or antecedent, meaning later on diagnosed with cervical radiculopathy and end up having ACDFs, they did much worse in our surgical response or surgical treatment. So clearly there's either a double crush, or there's some component of the spine that could be contributing to this. So you want to make sure, first off, it's not that. And EMG is a helpful way, not the only way, but a helpful way to do that. Secondly, occasionally it gives you, as Robert mentioned, a little bit more additional information confirming or helping to understand what's going on. At least in our series focusing on the arthroscopic treatment of the infraclavicular plexus, I think it was 8% of them had EMGs that were positive for kind of a very subtle suprascapular neuropathy that kind of goes along with the STAM that you mentioned earlier, the scapulodyskinesia, the scapulothoracic abnormal motion. When you have that, people often get suprascapular neuropathy from the compression of the nerve as it goes underneath the suprascapular nerve.
So the abnormal posture of the scapula creates tension in that little tunnel, that notch.
Exactly.
And
Exactly. It's a mixed motor sensory nerve that then potentially causes pain, especially radiating down towards the back of the shoulder or back of the scapula. So, I mean, that's been something that the French have sort of talked about, and others around Europe have kind of approached for a while. But that abnormal motion creates this, if you look at the suprascapular notch, the nerve goes underneath this tight ligament, and then normal motion doesn't matter. But if you have some abnormal motion, you can imagine how it could get tethered. So it's there's sometimes it's helpful, sometimes it helps to maybe rule in something else. Similar to sometimes imaging can be helpful in helping rule in, but also can help. And we've had occasionally where the imaging actually showed there's like a brachial plexus tumor, or there was a big cyst that was contributing to the symptoms, subcorcoid cyst or something like that. So there's a lot of stuff that you can get. And that's why I think having a comprehensive approach with getting a lot of different information, the more information, the better. If you try to do this based off physical exam, I think it's going to be a difficult road in treating this sort of complex problem.
Yeah, and then the number of patients, piggybacking on that, the number of patients I've seen that have come in and said, I went and saw so-and-so, they made me do a couple movements in the office, they told me that I had thoracic outlet, and then they said, well, you can do some therapy or we can do a rib resection. Like, that is not the way to go about this. And we hear patients come in frequently that is the approach that they've been kind of gone through, seen previous groups. And then the other thing I just wanted to piggyback on that was just to say, for people that may be viewing this, and if you're a patient, don't let anyone tell you do not have thoracic outlet syndrome based on a negative EMG. Just because your EMG doesn't show thoracic outlet syndrome does not mean that you do not have the condition. So it doesn't, because you have a negative EMG doesn't mean that you need to, fall into despair that you have no diagnosis. There's a lot more that we can do to work this up.
That's a great point. In the outpatient, non-academic setting, that's how insurance companies diagnose TOS. They rule it out with a test that will always be negative.
Right.
So we get that a lot. And most of the docs we work with who know something about TOS just, yeah, a negative EMG doesn't help us at all. Thank you. Herb, let's get one more or two more questions if we can. Hello, thank you for doing this. What are some non-surgical treatment methods that you recommend? And if you can discuss methods which you have found most effective. Okay, so you guys have covered some of this, but if someone is not going to go to surgery, what are the various conservative methods that you will try that have a reasonable chance of helping?
Yeah, and I'll touch on a couple things, and Eric, you certainly can weigh in too. But I would say from a go-to, we go through our algorithm and we figure out with patient which area is most dominant for their compression, or is it a combination of different areas, whether it's scalene or pec minor. I'll just leave it at those two for now. I generally will go through that. I'll talk with the patient. We have all the information from the diagnostic injections, and then we kind of lay out here are the surgical approaches to this. Here are the non-surgical approaches. And the primary non-surgical approach, or the most aggressive non-surgical approach that I generally will present to people, is Botox injections or botulinum toxin. There's a number of different brands. Dysport is one brand that insurance covers frequently. And these are things that we get insurance to cover. We run into some problems every now and then, but in most cases, we get insurance to cover the botulinum toxin injections. And it's that injection followed by aggressive physical therapy that we've already talked about, addressing posture and scapular retraction and working on periscapular muscle strengthening, and doing that diligently for a number of months while the Botox is active. So Botox takes about 10 to 14 days to even start working. Then you're just peak effected a month, and then is active for another 2 months. And so during that time, we want to be aggressive with that therapy, where we've given the muscles a kickstart to relax, and so that they can do the therapy. And that is kind of my primary go-to non-surgical treatment. There are others around the country. Ben Suture is a TOS doc. He's now retired. He was in the Phoenix area. There's an osteopathic physician that did a lot of osteopathic manipulative treatments from a manual therapy standpoint, that he found some success with thoracic outlet syndrome patients, and some of his papers are in the literature. And so I think that is an approach as well. And I think what we don't know quite yet, and I think we need a lot more data to tell us if this is helpful, is any sort of ultrasound guided hydrodissection of the nerve structures. I just don't think we can confidently say one way or the other whether that's really applicable in these cases.
Which for our listeners is?
It is, yeah. So it's basically you look with ultrasound, you take a solution. A lot of times it's a prolotherapy or a dextrose. So basically it's sugar water, so saline, a little bit of lidocaine, and some dextrose, which has been shown to be good for nerve health in the limited literature we have. And you dissect the nerve out from compressing structures around it. So basically it's injecting a large volume of fluid around nerve structures to dissect them out from areas of compression.
Well, if I can, I don't know if I'm going to share my screen. Is it okay if I share my screen?
We'll see if it works. Yeah.
All right, cool. You able to see this? Or no?
I can't. No.
Shoot. Okay. Basically, I was going to share with you our therapy protocol.
Hold on. There it is. Yeah, there it is.
Oh, you can see it?
I can see it now. Yeah.
Perfect. Yep. So for those that are interested, this is our sort of phased therapy protocol, where we expanding on what Bauer's sort of talked about, starting with a figure of 8 brace, kind of going through this progressive kind of scapular, kind of shoulder, kind of TOS type of protocol. And it phases as you kind of, depending on your progression, about a bunch of these different exercises that will kind of help to stretch, eventually retrain, and probably most importantly, then strengthen and kind of get you back into a normal phase that allows you to get back to various activities, depending on what you're trying to get back to, sports or overhead activities or weights or whatever that is. The idea is to kind of getting you back into a real, true algorithm of retraining your body, how to move your shoulders, how to move your scapulas, how to move. The figure 8 breaks, actually, this was a patient that helped me to understand how valuable this was. This used to be a way that we treated clavicle fractures. Super helpful though for that, fighting that protraction of the scapula, kind of opening up the thoracic outlet. Traditionally, this has been published on. I don't find this as helpful because it's people don't really like to wear it. And then these just shows different examples of like a chin tuck exercise, the crossbody stretch, obviously this sort of supine flexion exercises. And these are all different ones that I think are helpful. There's actually, each one of these is based off of some data early by Burkhart and some others that looked at the efficacy of opening up the thoracic outlet, opening up the kind of front part of your chest, and retraining things like the pectoralis minor. This is a standing corner stretch. I think this is a really mainstay for those that have this scapulogirdle phenomenon. And so there's a lot of these different exercises that we have that we find very helpful, both to strengthen, to sort of retrain how the shoulder moves, how all the different muscles move. A sort of moment on this, as you kind of see some of these examples of exercises, the glenohumeral joint, so the shoulder joint, is balanced by the rotator cuff as dynamic stabilizers. The subscap balances with the infra and the teres minor on the backside. And then the super balances with some of the other I'm sorry, looks like my screen froze. But the shoulder blade also is a balancing act. So the shoulder blade's balanced by different muscles on the front and the back that do internal, external rotation, that do protraction, retraction. And so this is all about kind of trying to retrain the shoulder blade to get that balance back and correct that sort of abnormal posturing. Also helps to kind of open up the area where the scalenes are, and helps to open up the area where the trapezius kind of controls. So these are all kind of different areas that I think are quite helpful. I think there's a lot. There's actually more than you think in the literature on what's effective, what's not effective, and so we've kind of compiled that early in our process and sort of made this as part of our therapy protocol and work with our therapists on this. So
wonderful. All right, we're going to take one more question here because of time constraints. Herb. Hi, Karina. My 15-year-old daughter has had 3 surgeries post-traumatic shoulder dislocation. 4 to 5 months post the second surgery, she began having scapular winging pain, weakness, numbness of the left arm in the 4th and 5th digits. She was sent to a specialist to do an MRI, ultrasound, EMG. We were told that based on the exams and the symptoms, she had TOS, and they mentioned surgery, but he was worried about doing it due to the risk. He just kept saying it's a very high-risk surgery. So she had to have a 3rd surgery to repair. I don't know if there's an additional. Okay, so first of all, again, I want to warn, we can't give out specific health advice here. We can talk about generalities, and I encourage you, Karina, you can get in touch with us, our website, and we can get you in touch with the right specialist for this. I have a suspicion you guys are going to say the same thing you said before, which is we don't know what this disease is yet. We need a lot more.
Yes. Yeah, I mean, shoulder dislocations or any type of really traumatic injury can be a cause of the TOS, or maybe whatever's kicking off that algorithm. So for sure that could be a cause, but shoulder dislocations can also be a cause of a variety of other nerve problems, maybe paralytic problems or subtle paralytic problems around the shoulder, maybe the shoulder blade, given the energy that it took to cause that. So some of the, you mentioned the scapular winging and the shoulder blade problems, that could be a nerve paralysis instead of an actual TOS event. I mean, there's a lot to impact, and then the little fingers, why are those being impacted? So there's a lot to impact there. In general, I think as a broad viewpoint, a shoulder dislocation event can have a lot of nerve problems that are both paralytic or maybe from a product of your body's adaptive response that then creates a dynamic compression. That's the beauty of high-level imaging. That's the beauty of a very thorough physical examination. That's the beauty of, if we do think if it is TOS, like the diagnostic injection. So a lot to sort of consider in this type of problem. Once again, as Bowers and I think if you can take home anything from this, I think the more information in these kind of complex problems you can get, the better. The more studies, response to injections, response to specific therapy, the more the better in this type of situation. And also, like, surgery should not be the first, second, or third option right away. And really, there's often a lot of things you can do prior to that, or you really want to make sure you have a very iron diagnosis before you jump into any surgery, whether it's an arthroscopic surgery or an open surgery. Gosh, you got to make sure you know you have the right problem, because no surgeries not without risk, especially these surgeries. These surgeries do have serious risks, much more so than, like, if you have to do a Tommy John surgery on the elbow, or if you have to do carpal tunnel syndrome. I mean, these are real surgeries, and so you really want to make sure you have the right diagnosis before you do that.
Wonderful. Thank you for the question. We are, D. Cell says, thank you for all the knowledge. Can Robbie speak to the process of treatment for out-of-towners? That's great. Do you have a process to help people get to lodging and travel and all that?
Yeah, so I actually just had this conversation with one of our out-of-town patients today, and I said, my part of this is really the part that creates problems for people, because the staged portion of injections really is important. So in most of our patients, there isn't necessarily a great workaround for that. We want to give it a few days for that injection to wash out before we do the next one. So sometimes it requires a couple different trips. Like, we had a patient I can think of recently that came back and forth from Florida 3 different times to do the diagnostic injections. And I understand that that's difficult. So there are, we do have people at Emory that can help, patient access, individuals that can help with those things. But as far as our specific TOS patients that our teams do, I wouldn't say that we have necessary, access to, funding and lodging and things like that. So that does, the stage component of the injections does make things a little more difficult. But it's kind of the nature of the beast if we want to get the correct information and get the most appropriate treatment.
If I can say one thing, though, we do often and still almost weekly or bi-weekly, we're doing this now, where when somebody comes in that we know ahead of time from out of town, we can't help it if they show up in the clinic and they haven't told us. But if we know ahead of time that they're coming, we can arrange for the imaging, we can arrange for the visit with Bowers and myself, we can arrange for the EMG, all to be performed hopefully in that first visit. And often we'll set it up where I'll see him before Bowers, and he and I will sort of discuss what's more likely based off the exam, based off of their symptoms, based off their problems, what's the most likely to have the best value if we're going to do one injection. And Bowers is right. Often we'll try to encourage them to come back for a second visit, but I do think many times we have a pretty good idea after that first visit, based off all the information, what we're dealing with, and sort of giving you the protocol, or giving out the protocol, and kind of coordinating from that. The other thing we can do, and we do, is when you establish care if you're not from Georgia, if you establish care in Georgia, then when we see you in Georgia, follow-up visits out of that we can do virtually for the most part, if it's dealing with the same problem that we're treating. And so we do a lot of virtual visits in that respect after establishing care initially in Georgia. So those that are interested in coming, we're happy to see you. Obviously, please through this source, or through any other, through, I guess, probably, what's the best way for them to reach out? Probably reach out to y'all, and then you can guide them to us. But if you're interested, we're happy to see you. We're happy to talk to you. The one caveat is we have to establish care in Georgia for us to give you actually true medical advice.
Right. I was just going to say, I was just going to piggyback on Eric and say the same thing. I did omit that part of it. Yes, sometimes it makes it difficult if they have to come back and we decide we want to do multiple injections, but exactly what Eric said, if we know they're coming ahead of time, we can arrange everything to be done for the most part in one visit, and we're going to do one diagnostic injection, and Eric and I will talk and discuss which one do we think is most likely to give significant relief. So that is definitely something I omitted, so we can do our best to try to make it one trip.
That's great. We've been putting up banners at the bottom with your phone numbers.
Sure.
People can certainly reach out to us, and we will pass on your email and your.
Yeah, please pass on my email. I'm happy to. People can email me, no problem. And what I'll do is I'll just put you in touch then with both of our schedulers. So.
I want to thank you both.
Fine with me too.
Dr. Bowers, Dr. Wagner, as truly enlightening. you guys have obviously put so much thought into this, and you're obviously thinking way out of the box on a lot of it. And I just feel warm in my heart that you guys have developed this protocol so far and are following it and harvesting the data. I think you're both to be applauded for being so gracious by sharing your time with us, with all the patients here. So hopefully we can have you on in the future, and hopefully I'll get a chance to work on a few patients with you, because I'm just fascinated. So thank you both very much. Two professors at Emory, Dr. Robbie Bowers, Dr. Eric Wagner. I'm Dr. Scott Worden, the TOS guy. Our website is tosmri.com, and we will gladly pass you on to whatever or whoever you need to help you. This is sponsored by toseducation.org. That's toseducation.org, who keeps a list of all our guests and our programs, our educational programs. Thank you all for attending, and we'll see you with our next visit. Take care.
Thank you.
Thank you.